During ESMO 2022, we had two very important presentations dedicated to MSI colon cancer. So MSI colon cancer is 5% of the metastatic patient and 15% of the non-metastatic patient. And we have had two trials. One was in the metastatic setting, second line with Avelumab, called the SAMCO-PRODIGE 54 trial from France. And the second one was for patients with non-metastatic disease presented by Myriam Chalabi from the Netherlands in the presidential session called the NICHE-2 trial and testing preoperative nivolumab plus ipilimumab. This year at ESMO, I had the privilege to present the SAMCO-PRODIGE 54 trial, which is a PRODIGE trial conducted in France in 132 patients, testing Avelumab versus standard of care second-line chemotherapy plus targeted agents in MSI-high colorectal cancer patients with metastatic disease. We know that immunotherapy is not a big success in colorectal cancer, except in these 5% of patients that are MSI-high. We have had the Keynote 177 published in the New England Journal of Medicine by Thierry André, showing that immunotherapy is efficient in first line. And now we are testing here immunotherapy in second line in patients that had not received immunotherapy previously. So not all patients are fully diagnosed first line. It is theoretically how it goes normally, but sometimes you see a patient that has not been tested and we find him MSI after a first line treatment. So this study randomized Avelumab versus a standard second line chemotherapy plus a targeted agent and showed that Avelumab is superior to the standard of care with a PFS objective that is reached and a significant improvement in PFS by using Avelumab, which is an anti-PD-L1 inhibitor and not an anti-PD-1 inhibitor. The tolerability is also in favor of immunotherapy. Clearly, there is less grade 3/4 toxicities, and most of grade 3 toxicities with immunotherapy are easily manageable and biologic disturbance, not clinically significant. And also, what we have seen is that some patients are resistant. This was already seen in, I would say, Keynote 177. If we look at 1 year, in Keynote 177, 50% of the patients had progressed, which means that not all patients are controlled for a long time. And we had the same picture here, but with a larger number of progression at 1 year, 70%. However, the one responding initially are responding for a very long time. And if we have 30% of patients still controlled at 1 year, we still have 25-30% at 1.5 years and 2 years. So it seems that when the control is there, it's for a long time. So this is an interesting study because it means that if you find a patient without immunotherapy first line, you have to do it second line, but probably also indirectly that you have a bit better result if you use it upfront, so test your patients. This year at ESMO 2022 in Paris, Myriam Chalabi presented the NICHE-2 trial results in the presidential session. This is a very awaited trial because we have had the publication of NICHE-1, which was 40 patients, MSI-high, with a resectable non-metastatic colorectal cancer, colon cancer, that were treated with preoperative nivolumab plus ipilimumab 1 cycle, then nivolumab 2 weeks later, and then surgery within 6 weeks from treatment start. So it's a very innovative way of doing things. The pathological complete response rate was very impressive, and NICHE-2 is the same design, the same kind of patient, but with a larger cohort. So we are moving from 40 to 112 patients now to confirm these results in a larger cohort and to be sure that we are maybe in the future going not to go to surgery for such patients. So it's a paradigm change. It's a very important trial, to my opinion, even if it's not randomized. So it's a single arm with this immunotherapy preoperatively, and they found that 95% of the patients had a major pathological response. 67% of the patients had a complete pathological response with no cancer left. So it means that maybe in the future, the strategy of watch and wait that is already in place for rectal cancer after radiochemotherapy may be an alternative, an opportunity in patients with MSI-high colon cancer without metastatic lesions that are resectable. Most of the tumors were quite large. It's not maybe the very easy removing because the surgery in colon cancer is not the surgery in rectal cancer. It's not the same issues. And the second thing is that they compared Lynch syndrome to sporadic MSI colon cancer, and they found that maybe the response rate, pathological response rate, was a bit better in Lynch syndrome as compared to sporadic patients. So a very important study that may probably change the practice in the future, but there are many other studies ongoing trying to confirm these kind of strategies.